Okay, so good evening, everyone. It's Wednesday, the 12th of January, 2022. Happy New Year from all of us here at BOMSS, and welcome to the inaugural Journal Club this year, hosted by the Welsh Institute for Metabolic and Obesity Surgery. I'm Sharif Fawad, consultant bariatric surgeon at Derby, and I'm educational lead at BOMSS. Thank you very much to Ethicon for sponsoring tonight's session. We've got over 90 participants registered, okay? And before we get started with tonight's session, I want to just advertise to you the next educational webinar, which will be the last Wednesday of the month, 26th of January 22, and I've invited Mr. Javed Raza Ahmed, who's a consultant bariatric surgeon at Cleveland Clinic Abu Dhabi, and I've given him the task of speaking to us about sleeve complications in patients who seek health tourism. Okay, so Javed will take us through that. Should be a fantastic talk. But back to tonight, it's my pleasure to introduce John Barry, Andy Beamish, Scott Kaplan, who are going to be chairing and presenting the Journal Club tonight. My co-host for this evening is Sally, known to everybody. So Sally Abbott, who's on BOMSS Council and dietitian, and thank you very much, Sally, for joining me tonight. Okay, so we'll go to Andy if you want to take over and introduce our first paper and our first speaker. Thank you, Andy.
Thanks very much, Sharif. So as has already been said, we're delighted to host this episode of the Journal Club. The three of us tonight who are on the call are Professor John Barry, who is lead of the WMOS, Welsh Institute of Metabolic and Obesity Surgery, and Mr. Scott Kaplan, who's also an upper GI and bariatric surgeon in the same unit, and myself, who's just been appointed as an upper GI surgeon in the same unit. So fresh out of training and ready to get started in consultant life. So we're going to start off with Professor Barry, who's going to talk to us about this first patient, which is the Allied Health paper. Off you go, John.
Thanks very much, everybody. Many thanks, Sharif, for the very kind invite. It's nice to be here this evening for what is the first Journal Club of 2022. I'm grateful to Andy because he's got control of the computer, so he's going to be the one who's going to be changing the slides over for me. So if you can change to my first slide, please, Andy. Croeso, that means welcome in Welsh. Welcome, everybody. So we've got two papers for you. The first paper that I'll be presenting is the Allied Health paper regarding questioning the legitimacy of bariatric surgery, a qualitative analysis of individuals from the community who qualify for bariatric surgery. Now, this has been published in Surgical Endoscopy, a good surgical journal, good impact factors. I'm sure you're aware, the higher the impact factor, the better the quality of the journal. Impact factor of surgical endoscopy, I think, is about 4.5. And this paper's already been presented at the SAGES meeting earlier this year, in the middle of last year, Society of American Gastrointestinal Endoscopic Surgeons. I'm just going to talk you through it. Next slide, please, Andy. Oops, there we go. So essentially, this paper was a qualitative analysis of attitudes to bariatric surgery in patients who are eligible for surgery. So these are patients who haven't been enrolled in any type of weight loss program or any surgical program. They've just been assessed for their attitudes to what bariatric surgery is. It's a rather diverse cohort. They've targeted predominantly a non-white selection of the population. And essentially what they've shown is a failure of legitimacy of bariatric surgery as a treatment. So the understanding of bariatric surgery in this cohort of patients, they feel that it's not a legitimate treatment strategy. There's essentially a perception that surgery is commercialized, and we're going to talk about that in a minute. Very few of these patients have had discussions with their primary care physician. Obviously, in the United States, you don't have general practitioners. People go and see a primary care physician. And few of these patients have had discussions regarding bariatric or metabolic surgery. And there's also some conflicting ideas over what they perceive to be bariatric surgery-related diets and weight loss. Next slide, please, Andy. Back one there. Okay, so what was their hypothesis? I accept this as a qualitative analysis, but what they essentially felt was that there was a poor understanding of the perception of what bariatric surgery actually meant in these patients who qualified. So these patients were all eligible to undergo bariatric surgery, but what was their perception of what bariatric surgery actually meant? And not only their perception, how would this affect their likelihood of seeking bariatric surgery via their primary care physician, or indeed going themselves to a metabolic surgeon in the private sector? They did note there's been previous studies focused on patients who are actively engaged with weight loss programs or awaiting bariatric surgery, but none of these patients were engaged with any type of process. They also noted there were a few studies previously on racially minoritized communities, but as I said, this study purely looked at a disproportionate number of patients who are from racially or ethnically minoritized communities. Next slide, please. So going through this paper, I think some of the strengths are, it's actually a small part of much larger qualitative analyses of the barriers in patients going forward for bariatric surgery. As I've already mentioned, they're a racially and ethnically diverse cohort. They're very clear about their inclusion criteria, and certainly these patients are all eligible to have bariatric surgery. So they're all over the age of 18. They all have a body mass index of greater than 35 with a comorbidity that would improve by having surgery, or indeed a BMI greater than 40. All of these patients were assessed by face-to-face interviews prior to COVID-19. They were interviewed by 2 independent interviewers. All of these interviews lasted between an hour and a half. They were all audio recorded and transcribed by professional transcribers, and they were checked. I feel the data analysis in this paper was appropriate for qualitative analysis. Next slide, please. From the very outset, I felt the numbers that they've got in this paper are actually quite small. I mean, if you compare this paper to the next paper that Andy's going to present, looking at 175,000 patients, there's only actually 32 patients involved in this study. And that sort of raised my eyebrows to start with, but they were quite clear that they found 30 individuals provided enough strong information power at the end of their study for it to be relevant. I was also unclear from the outset as to why they targeted non-white individuals. I've also mentioned that this limitation is because it's a qualitative analysis. Speaking as a surgeon, it's easier to look at quantitative analyses because there's something that you can actually measure. You're not looking at words in quantitative analysis. So I'm always slightly skeptical about these type of papers. Next slide, please, Andy. So here you have the start of the results. As I said already, there's 32 participants. Fewer than 20% of the patients were white. About 88% of them were female. 2/3 of these patients were working full-time. I think what would be interesting in this paper would be to break down what type of jobs these patients were in. Were they professional roles, non-professional roles, whatever, but they felt in order to maintain anonymity that they wouldn't include that. Obviously, this paper comes from the States. It is from the southeastern Michigan. And so clearly there's a difference in how healthcare is provided in the States. And no fewer than 87% of these patients had their own private insurance or had some form of Medicaid, Medicare covered. And it's quite interesting, despite the fact that Roux-en-Y gastric bypass is the most commonly performed operation in the United States, bar none, that 2 of these patients had never actually heard of bariatric surgery. Next slide again, please. So when looking at the results, there's a lot of information to take in because it's qualitative. There were very, very many negative comments, particularly lacking the legitimacy of this type of procedure. A lot of these patients felt that bariatric surgery the perception was it was a commodity. And lots of comparisons were made with cosmetic surgery, such as, I don't know, fillers and breast augmentation. A lot of these patients also felt that this wasn't perceived to be part of mainstream medicine. It wasn't perceived to be something that was going to improve their general health. And also, quite a significant number of these patients, although they don't give absolute figures, a lot of these patients had seen primary care physicians regarding their weight, but none of these primary care physicians mentioned the possibility of bariatric surgery. Next slide, please, Andy. So there's a few, obviously, qualitative analysis. There's a lot of comments here. Bariatric surgery was seen as for profit. Participant physicians had not ever discussed bariatric surgery. Confusing information surrounding bariatric surgery related diet and weight loss. What they mean by that was, or my interpretation of what they mean by that, is that if patients are told they're going to have an operation that's going to reduce the amount of food that they consume, they're not going to be as hungry, they didn't make the link between that being an effect of having an operation. And what they felt was, well, if I can just reduce the amount of food that I can eat, I wouldn't need an operation. So there's lots and lots of questionable legitimacy about this type of procedure. Moving on, please, Andy. So my reading of this paper was the major barrier is the legitimacy of surgery in this cohort of patients who were eligible to have this type of surgery but did not proceed because they felt it wasn't effective. There is a need to improve the understanding of bariatric surgery as a proven treatment modality. And although I've seen instances of this in the United Kingdom, I was quite surprised to see such a prevalence of it in the United States. I think what we need to do is we need to change this misperception of the benefits and advantages of bariatric surgery. But also, I would draw attention to the fact that a number of these patients, 40% of them said that their primary care physicians had a very negative aspect, negative views regarding bariatric surgery with regards to post-operative complications and ineffective weight loss. So my overall conclusion is, do I like this paper? Well, from reading it from the start, I thought, well, we're talking small numbers here. You can't really make meaningful interpretations of what they're producing. But I do actually like it. I like the fact that, you know, they have brought to the forefront. It's not because they've got a disproportionate number of, racial, ethnic minorities. But the fact of the matter is that we have a cohort of patients here who are eligible for bariatric surgery. Their perception is that it's not legitimate. It's not going to work. And for this reason, they're not taking things forward. I would like some feedback from you folks, particularly the allied health people. I would like to know from my colleagues here whether or not you're aware of any similar studies from the UK or indeed Europe. Thank you very much.
Excuse me. Nice one, John. Thank you. Very nice and succinctly presented. And it's quite hard for surgeons to sort of interpret the qualitative papers, but I think that there's definitely a value to them in exploring difficult questions like as these. And I don't know, certainly in our service at Derby, we haven't gone out to our clients, to the patients, to see what their perceptions are or what they would like from our service that we are offering. And we think we're doing what patients want us to do, but we've never actually asked them what they want us to do. Sally, you got any comments?
Oh, I've got so many comments. It's a really interesting paper. Thank you, Jonathan, for picking it. And thank you for picking a qualitative paper as well, because I think, like Sharif alluded to, we can gain so much from quantitative, but we can't get all of this really rich data sometimes. So yeah, really interesting. I think it's more of sort of a point about the fact that it's really great that the paper was looking at ethnic diverse population. And I think particularly from where I work in the West Midlands, I'm sure Sharif will agree, I don't think in Wales it's as ethnically diverse, but I've definitely noticed that our ethnic minority patients are the least likely to come forward for bariatric surgery for the reason that was mentioned in the paper, that actually a lot of the kind of communities and the culture sees that actually if you want to lose weight, it's almost vain. It's almost like a cosmetic reason, which I think is also what that paper was alluded to. And I just wondered if that's something you've come across in your clinical practice, and if you have any thoughts about actually how do we get that message across that bariatric surgery is a medical intervention and it's not cosmetic.
Well, I agree completely. I mean, we're quite ethnically diverse in South Wales, particularly in Swansea and in Cardiff, when I live. And the irony is that these type of individuals have more to benefit from having bariatric surgery, which is why we've modified the NICE criteria in recent years, is that we should be aggressively going after the lower BMIs in these communities. There is a perception that is cosmetic. I think what I found staggering from this paper is that, you know, all of us on this call tonight realize the benefits of these type of interventions. I just, whenever I meet patients, I say, this is going to be good for you. I don't know what the barriers are in those communities. I think we've just got to increase our education sessions with primary care, try and get out there, educate our colleagues that, you know, these patients should be put forward for surgery, and try and break down those barriers.
Absolutely. And I think it's interesting because a lot of my patients from ethnic minorities, there's quite a number actually that haven't even told their family, friends, colleagues that they've had bariatric surgery. There's this element of almost shame, and I'm sure if there's any psychologists in the audience, they might want to comment on that as well. But I think it's a really important point. Like you said, the patients that would probably benefit the most from bariatric surgery are almost the most fearful or shameful of having bariatric surgery. So yeah, really interesting points raised from that paper. Should we have a look at some questions from the audience?
Yeah, so there's one of our colleagues has got a question for you, John. So as the research was conducted in marginalized community members, do we know how this will affect sort of their interactions with their doctor and some of their views?
I'm not sure. That's a very good question, actually. I'm not sure that hasn't been touched on this paper at all. But that's a very good question. But I'm afraid I can't add much to that.
Okay.
Mm. And I suppose it's interesting because even though they're from marginalised communities, I think you said nearly 90% had private healthcare insurance, which perhaps alludes to the fact that actually it's not perhaps a socio-demographic that we see a lot in the UK as well.
Yeah, well, certainly. I mean, obviously, in the States, we don't have there isn't a national health service. Notwithstanding, there's no national health service. Obviously, a lot of people are undergoing bariatric surgery in the States, but no, it was quite surprising to see 87% of people have some form of health insurance stateside.
And Vinod has alluded to a couple of the well, at least one of the initiatives that BOMSS has been doing, working with the National Pharmacy Association to produce appropriate literature to give to patients in the pharmacies to help to educate them, to engage with pharmacy professionals, perhaps taking on the role of advising about obesity instead of the busy GPs out there. So hopefully we'll see the fruits of that piece of work in a few years' time. Scott, I think you've put a comment that you'd like to say something.
Yeah, I was just going to add a couple of comments looking at it slightly differently. I mean, I, like John, quite enjoyed this paper at the end of it. And I didn't think I was going to when I started reading it as a qualitative paper. I think we have to take account of where it's set and the ethnic diversity and the different healthcare structure. And I think very little of it is directly applicable to our practice. So in Wales, I think we do see underrepresentation of ethnic minority patients. But I think it will be a bit taking it too far to start reading into we understand why that is in any way, shape or form, because I think our ethnic diversity is very different and we get different reasons. They make a comment that almost all participants who had a primary healthcare physician, they don't actually tell you what proportion had primary healthcare physicians and what proportion of those, when they talk about, you know, those that where the primary healthcare physician did or didn't mention it. But I think there are some messages we can definitely learn. We need to engage more with our primary healthcare physicians to make sure that they understand the benefits of bariatric surgery, and they are talking about bariatric surgery and metabolic surgery in favorable terms when they're dealing with people with appropriate indications. And we need to work on getting the message out there in the appropriate fashion for our own populations.
And just today, actually, I saw on LinkedIn a very good publication which Ethicon helped with, working with some of the patient advocates to explore some of the stigma around and the misconceptions around obesity surgery. So it's worth having a look at that. It's just came up on my LinkedIn feed earlier on today. Okay, so with time marching on, shall we move on to our second paper? So I think, Andy, you're going to present the medical paper.
Absolutely, yeah. Thank you very much, Sharif. So moving back into, for many people, probably more comfortable territory, this is a very large, actually, meta-analysis, which includes almost 175,000 participants. So a really gigantic number of patients involved, and quite impressive to deliver. Many of you who've been involved in obesity for a long time will recognize some of the names in there, in particular David Cummings, Lee Kaplan, John Dixon. So we can tell from the beginning, right from the outset, that this is probably going to be high quality. You can see in big letters up there the word Lancet. And of course, that gives you a clue as to the quality that this paper is going to contain within it. At the moment, the Lancet's almost at 80 for its impact score, actually. So it's gone from strength to strength as one of the premier medical journals. So a little bit of background to the topic. We saw the title. It's the association of metabolic and bariatric surgery with long-term survival in adults who have and do not have diabetes. So they looked at overall survival, and then they compared in subgroup analyses those with and without diabetes, meta-analyzed the data they could find that was high quality. So again, for the background, we're talking about metabolic surgery, and this really rams home the importance of metabolic as opposed to just thinking about bariatric surgery. You know, it's the same techniques, but thinking in terms of metabolic improvement is the name of the game when you look at this paper. There is pre-existing overwhelming volumes of level 1 evidence for type 2 diabetes treatments involving bariatric surgery, so that we know that surgery can induce remission in people with type 2 diabetes, or many people with type 2 diabetes. We also know from the literature, which is meta-analyzed in this study, that there is a survival benefit. And we've now got to the point where actually this study is really timely, because combining those data from separate long-term studies has become really important so that we can draw more meaningful conclusions. You can see in that table the number of randomized trials, and this is from 2016 when Phil Schauer was publishing the benefit in terms of diabetes remission. And yet we still underuse it in type 2 diabetes because it's an operation. So to summarize the paper itself, this is a meta-analysis of 17 studies, one of which was randomized, and it examines survival after bariatric surgery with or without type 2 diabetes in sub-analyses, but overall survival from metabolic and bariatric surgery. The outcomes showed that metabolic and bariatric surgery almost halved the risk of death, and life expectancy was extended by almost twofold in patients who had diabetes at baseline. There was no survival that they saw, no difference in survival that they saw according to the procedure type, but we'll talk briefly a little bit about that later on, as we probably can't transfer that to, we can't be confident in that outcome. So looking at the introduction is very good at clearly outlining the need for this meta-analysis. And I've highlighted here a couple of bits that drive that message home. So the studies that exist already from which this pooled analysis is taken, survival is the primary outcome. And so in bariatric surgery, because of the incredible leaps that we've taken over the last 6 decades, we've come to a point where actually, not unlike Mason's first series, where we had an 8% death rate in bariatric surgery, the number of deaths is so very low that actually you can't really draw meaningful conclusions without enormous numbers and follow up for a very long time. So if you're operating on 40 to 50-year-olds as a median, you're going to have to follow them up for a very long time after bariatric surgery before they actually reach your primary endpoint of death. There are a huge number of strengths in this study to talk about, but we only have just over 10 minutes. So to be succinct, it's definitely methodologically strong. There are meta-analyses and there are meta-analyses, and this is a very complex, statistically dependent meta-analysis that required certain things, which we'll come to later, which are atypical from a normal meta-analysis. As I've said already, they had an enormous number of patients, which together amounted to 1.2 million patient years. So a vast amount of data to look at, which gives it really high power to draw meaningful conclusions from. Importantly, only 2 of the studies were published before 2015. So whilst we've seen that rapid and substantial increase in improvement in outcomes in bariatric surgery in recent years, it's very easy to look at data that shows you actually studies from the late 90s, early 2000s, when there was an increase in bariatric surgery. But almost all of these patients were drawn from modern studies looking at survival. But you have to bear in mind actually that those patients who are looking at survival at 10, 15, 20 years in 2015 were actually operated in the late 90s or early 2000s. There were almost 2,000 patients followed up per group, by 20 years, which is a huge number for 20-year follow-up, and shows where we're getting to as a field in terms of following these patients importantly, not just for a couple of years, but into the long term. They've used the appropriate checklists, and they've used appropriate searches using multiple databases. And that underlined bit at the bottom about patient level data extraction, we'll come to a bit later. Limitations of the methods. They had to model the median survival because, again, for the same reasons we've already discussed, if less than 50% died in follow-up, then, which obviously we'd like to see, and we're very glad to see, you can't actually ever get to the median figure. So you have to model it, although they did use the same methods that the SOS study has used. And so that meant that the modeling appears robust. So it's probably quite reliable how they've done it, even though it's not ideal. They talked a little bit in a paragraph about the global potential life years gained. And for me, I'm not sure how this snuck into the Lancet, this paragraph, because I just think there's too many different variables and it's the product of these things that I've highlighted in the different colors. Every time you add in a new variable, multiply it by the previous to get to this final figure, you're just increasing decreasing the reliability, increasing the inaccuracy quite substantially potentially. So I'm not sure I can really believe that as a figure, and that's a limitation for me. In terms of the results, so the median follow-up was almost 70 months, and the hazard rate for death, so the rate of death was almost half as much in the surgery group compared with non-surgical management. The number needed to treat, so how many patients we needed to treat in order to stop one patient dying over 20 years was 11, and half as much in type 2 diabetes, in fact, less than half as much. So you only need to treat just over 5 patients to stop one of the diabetic patients, the patients with diabetes, dying across the first 20 years, which is pretty impressive. Then life expectancy was extended by 5 years in those without diabetes, and almost twice as much in people who had diabetes. And they talked about how there was no survival difference according to the procedure type. And I said I'd talk a bit more about that. The bit that I've put underneath it shows that what they've used to actually estimate this is the heterogeneity between the outcomes. And by their own confession in the discussion, it's not the most accurate of predictors, and it's not exactly the way that they would choose to analyze that if given other options. So we have to take that with a pinch of salt, and they confess that they need more research and better papers with good follow-up to compare the different procedures. So I thought we'd look at a couple of the, for educational purposes, if nothing else, look at some of the figures. And most of you will recognize this as a forest plot. And a forest plot shows us a line at 1 down the middle. And if the squares and the lines are to the left of this line and the number is getting lower at the bottom, then it favors whatever treatment's on this side. It's cut off the bottom here, but that's the surgery side, of course. And if the number is above 1, then it favors the non-surgical approach. And you can see that all of these boxes, the boxes, of course, represent the size, the number of patients as a proportion. So the bigger the box, the more the patients, and the medians in the middle. So this is the overall effect. And you can see, as we've discussed already, the risk of death comes down by almost half when you look at all of the papers combined, so all of the data combined. The yellow bit at the top highlights those 2 papers that were prior to 2015. So that shows you less than 10%, as I said before, were older studies, perhaps with older techniques as well. And also it's important, we often see Kaplan-Meier curves when we're looking at survival analyses. And you can see here the patients with type 2 diabetes on the left of screen, they have curves which have a gap between the different confidence intervals. So the line is the median, and they've got the confidence intervals up to 95% going up and down. And you can see there's a big space between them. Confidence intervals don't overlap from a very early stage. At 5 years, 10 years, 15 years, and 20 years, patients with type 2 diabetes who have surgery do much better than non-surgical control patients. In patients without 2 diabetes, the difference between the groups is less pronounced. And so although there's a difference between them, we've already talked about the data and the results. A couple of other discussion points, just to wrap up. So I've put this little block on the screen, and what it actually is a zoomed in part of one of these Kaplan-Meier curves. It's this little part over here. And I've just zoomed in right in onto it. And it was something I haven't seen done before, actually. So what the statisticians have done in this study is they've extracted patient level data from high quality, high resolution Kaplan-Meier curves, which is very clever because of course the Kaplan-Meier curve represents every single jump up that it goes is a patient. So if you have a big jump like this, you can measure the distance between there and there, and divide it by a block, and you know how many patients died at that period on the Kaplan-Meier curve. So they've used those to reverse extract patient level data. So they're not comparing the more usually used figures of medians and means and standard deviations and those kind of data. What they can actually get down to pretty accurately is the patient level data. So that was novel to me, and I thought was very clever. Then perhaps the most important point for me about this paper is the fact that, and I think this is why it's in the Lancet, is that its potential to impact on policy demonstrates that by this group bringing together in collaboration all those different good quality studies and meta-analyzing their data, they've come up with something that actually has the power, which none of the other studies did, to impact upon policy at a global level. If we think about the UK level, you can see on this chart over here, this is MBSR3 data. So it's the 3rd edition of the MBSR. And you can see that we've been stagnant on operating numbers in this country, despite the obesity levels that we have, and barely making a dent on patients with obesity as a population. And even, the trend realistically is actually downwards. We went up in 2019, but we all know what's happened in 2020, 2021, and it's going to be much, much lower. So we've got a downward trend. We're not picking out people as well as we could who would benefit the most from the surgery that we have to offer and the management that we have to offer, of which surgery is a small part. And this kind of research has such a great potential to impact on policy that's one of the reasons why I think it's really, really important. So in conclusion, I think this is a really high quality and high impact meta-analysis beyond perhaps any other meta-analysis in bariatric surgery I've ever read. It definitely has the potential to influence policy, but we all know that there's lots of things that should influence policy and unfortunately don't. But the more studies we have like this, the more high quality impact drivers we have at our disposal when we do start to have the conversations about improving the service that we provide. So I think we're back onto Q&A again.
Andy, thank you very much, and thanks for delivering a masterclass in taking apart a very complex paper and presenting it beautifully to your audience in the time. So thank you very, very much for that. I think it's a super paper, lots of data, it's modern. I've learned something from the patient level extraction, as you have. I've not come across that personally myself. And I think it's down to us really to publicize, to use the data, to get out there. What would you do if you sat on BOMSS and you had this paper? What would you do with it to try to influence policy and to influence the people local to you and regional to you who hold the purse strings?
I think it goes back to what John was alluding to from the first paper. I think there's actually a very similar message in what we can do with this paper and what we should do with patient perceptions. I think we need to make sure that not just patients, not just bariatric surgeons, not just allied health professionals in obesity, but the medical community, the public at large, that people really recognize that actually type 2 diabetes is indeed a progressive and potentially aggressive and very debilitating disease that affects every single organ system from head to toe. But it doesn't necessarily have to be unrelenting. It doesn't necessarily have to be unstoppable. We do have something in our armory that involves an operation that has the potential in many patients, in a vast majority, in fact, especially those diagnosed recently, to reverse it. And knowing those data is normality to everyone on the call, I'm sure. But those data being in the community, and when I think about the first paper, the people in there were saying they trust their healthcare providers, their primary care physicians, their specialists, which says to me, there's a first place to go. We need to have education programs that reach the people whose trust the patients have. who have the patient's trust rather. Giving them the knowledge and making sure they have the knowledge is one step. And, you know, we have to be realistic. Giving someone knowledge is not ensuring they use it, but making sure that people have the knowledge. Going out to the diabetologists and saying, actually, you know, is there a pathway to make it easy for you to get your patient who needs something to me, who can provide it, to our team? You know, I think that we have to go for the low-hanging fruit and say, how can we open the doors to both knowledge and movement of patients into treatments that can help them?
Okay. If your CCG came to you and said, we'll allow you to do 150 cases in a year, you choose them. And I know you serve a huge population in Wales and we need more centres in Wales. Would you just limit the surgery to patients with diabetes, given that they have the most to gain, or how would you approach that particular challenge? I don't want to say the word ration because we don't want to ration. This is good stuff, right? But what would you do if you were leading your unit?
Really tough question. That's a nasty one for me. I think we do need to get better at not calling it rationing, at choosing the patients who stand to gain the most and working hard to expand the number of patients we can serve at the same time. But if I've got the very same patient in front of me who has a new diagnosis of diabetes and a twin brother who doesn't, or twin sister who doesn't, I think the person with diabetes has more to gain than the other person. But, you know, we have to take diabetes is one comorbidity, and we have to take into account the metabolic health in general. You know, diabetes is an extreme metabolic comorbidity because it can progress quickly. It can, you know, affects every organ system, like I said. But we have evidence in the field of diabetes. We don't have so much evidence in other comorbidities. And so if we're going to practice evidence-based and base our ethics on evidence basis, then I think we do have to concentrate a lot more on treating things like diabetes, where we've got clear evidence that we can do some real good.
Okay, thank you. John, do you want to come in? Is there anything you want to add before I ask Sally to take the questions?
Difficult to add much to what Andy's said there, actually. I thought that was an exceptionally good presentation. Very strong paper, and absolutely we need to be getting the message out there to our diabetology colleagues, to our general physicians, that we can do something with these patients. And yes, I feel that we should be focusing on early onset type 2 diabetics, but we know there's 240 conditions out there that are caused by morbid obesity, if not exacerbated or accelerated. So there's lots and lots of patients out there that we can be helping, and we need to be doing a lot more surgery.
Agree. And you know, BOMSS is hoping for 20,000 a year minimum. So Vinod is working really hard with the powers that be to try to make that happen, Vinod and Council. Scott, do you want to add anything before we go to Sally?
Yeah, I was just going to say, if the chief exec came along and said, I'll give you money to do 150, how do you want to spend them? I'd say, well, if you give me money to do 300, I'll save you even more money from your ongoing diabetes costs than if you let me just do 150. So I think the choices to make ethically between diabetic and non-diabetic can be very difficult. But from a financial point of view, I think we can use lots of arguments to convince the controllers of the purse strings that it's beneficial to give us more money.
Okay, fantastic. Sally?
Yeah, really great job, as everybody said, of explaining some really complex statistical stuff there. I think perhaps what this paper's highlighted is the fact that we have to present a range of evidence whenever it comes to decisions like this, particularly when it comes to our commissioners, because a commissioner could easily say, well, if it only takes 5, the number to treat is only 5 for type 2 diabetes, why would we bother with all the other patients when it needs to be 11? So I think it's all about kind of presenting all the evidence we have available. And it's a really strong case for treating type 2 diabetes, but what this paper hasn't captured at all, and you referred to the word debilitating, that obesity is a debilitating disease. it doesn't capture quality of life. It doesn't capture the wider economic kind of impact of bariatric surgery. So I think I haven't really got a question so much. It's more just, I think what this is really nicely emphasised, particularly when we've had a mix of a qualitative paper and this quantitative paper, is that we need a range of different evidence to actually fully make decisions. And it's important actually what we're presenting to our commissioners to make sure that they're not excluding specific patient groups. It was more a comment really. I don't know if you had any thoughts about that, Andy.
Yeah, I totally agree about the quality of life things. And that, again, just feeds straight back into paper 1, where we're talking about what patients actually want from their surgery and from their management programs. And I think, the bi-band sleeve study, is exemplary. It's got so much, it's got quality of life at its heart. And that team delivering that, massive team, have done a fantastic job. And getting that across all those years ago, when they were protocolizing, to have quality of life so embedded in it, I think is fantastic, because there's so many studies that have great data from a physician's perspective or a surgeon's perspective, and we just don't know what the patient's thinking. And often when you ask them, it's nothing to do with what you thought. And so I really think that in every bariatric trial, we need to collect patient perspectives and quality of life data and those kind of things that, they might not necessarily be the primary endpoint or co-primary endpoint, like in bi-band sleeve, but getting those perspectives, that rich data that you mentioned before, is so important to delivering a service that actually serves the people that we're here for.
Just a question come through, Andy. See if you have an idea about this. Are you familiar with any CCGs using scores for giving patients different priorities for metabolic surgery? In your health boards and CCGs, have you come across that?
Not directly myself. I wonder if John might be able to say something about the history of how before we used to use NICE guidance in Wales.
We're still behind the curve slightly in Wales. We're still adhering to 2008 guidelines, and we haven't moved things forward. But specifically to answer your question, I'm not familiar with CCGs who are using scores to prioritize patients. I mean, we've just got so many patients that we need to operate on. I'll utilize any score that they give me, but I'm not familiar with any scores, I'm afraid. Sorry.
I know in our CCG there's a pot of money, there's a meeting, there's 1,000,001 priorities, and they have to dish out that money to the priorities. But I mean, our hospital, certainly we're not having payment by results anymore, and the hospital is given a block contract, if you like. So it's a block payment to serve the upper GI needs of 500, 700,000 people, etc. Okay, so as a service and as a hospital, we choose what we want to do. But if you do 300 bariatric patients one year and 500 the next year, you're not going to get any additional money for the hospital for doing the extra 200 cases. So it's difficult. It's really, really difficult. I think most places in the UK have moved on to not a block contract as such to do bariatric surgery, but they're given that form of payment to do X number of cases based on last year's volume and so on. Okay.
Hard to progress when you have to base your
it is
on last year's. Yeah.
No, absolutely. Okay. Well, time has drawn to an end, so thank you ever so much, team from Swansea, and Sally. Thank you very much for co-chairing with me. Thank you for joining, and see you all on the 26th of January. Okay, good night.
Thanks very much.
Good night.
Yeah.
Bye-bye.
No star.
No star.
No star.